caused by the loss or lack of expression of paternally imprinted genes in a specific part of the long arm of chromosome 15. And these genes are believed to encode proteins important in neurodevelopment. So deficiency of these genes and these proteins results in a very complex disorder, which includes hypothalamic dysfunction. There are two mechanisms principally for getting Prader-Willi syndrome. There are others, but these are the most important ones. Firstly, you can inherit a paternal 15 chromosome, which is deleted in the critical area. If you inherit a deletion from a maternal chromosome 15, then that gives you a completely different condition called Angelman syndrome. The other way of getting Prader-Willi syndrome is to inherit two maternal chromosome 15s, either two copies of the same chromosome 15 or one copy of each. And that way you miss the paternal contribution, you miss the paternally imprinted genes. So this results in the classic phenotype of Prader-Willi syndrome. I've listed the main features here, which include hypothalamo-pituitary dysfunction affecting the growth hormone, gonadal, and adrenal axis, hyperphagia, very, very important and serious feature resulting, if unchecked, in morbid obesity, type 2 diabetes, and death, hypotonia, learning disability, which is actually quite mild. It's not that severe, but very important behavior problems, including temper tantrums and significant psychiatric problems. So I'm just going to talk about the gonadal axis today. And the foundation of my talk is a 28-year study that we did in Glasgow. And what makes this presentation particularly special to me is that two of my co-authors are Egyptian. Professor Heba El-Sedfi came over in the mid-1990s, and it was she who actually started the study with the data collection. And Professor Sameh Taufik played an important role in coming to Glasgow and helping us to collect normative gonadotrophin data, which I'll refer to in a moment. So this is our cohort, 93 patients, 56 males, followed up for a median of 11 years, so quite a long-term follow-up. Deletion and disomy were the principal causes, as you can see. 11 of our patients have died, almost all due to morbid obesity. And when we wrote the study up in 2020, the patients were aged about 19 years. So what I'm going to do is I'm going to start by giving a little sketch of the biochemical findings, because I think they're very interesting. Then just go through the key findings of our study in males, the key findings in females, and then that will be the basis for giving a talk about the management of males and females from birth to 18 years. And along the way, I'm going to make some suggestions for potential research projects. I'm retired, I can no longer lead research projects, but I've got some ideas that some of you in the audience might like to think about. Because Prader-Willi syndrome is so rare, there would only be about 24 patients at any given age in the UK, of which half, of course, would be male, half female. Any study in Prader-Willi syndrome, I think, has to be national or possibly international. So off we go. I'd like to start off with showing you this slide. This is the LH levels in females according to age, 2 to 5 years, 5 to 10, 5 to 11, 11 to 15, 15 to 20, and above 20. And on the left panel, we've got the basal LH levels. On the right-hand panel, the levels after LH-RH stimulation. And here, you've got the normative data collected by Professor Sameh Taufik in Glasgow. And what I want you to notice is that actually the gonadotrophin levels before and after stimulation are not different between females with Prader-Willi or controls. And if you look at the FSH levels in females, they're not different to controls. The LH levels in males are not different to controls. And finally, FSH levels, yes, they are higher in males who are pubertal. Males beyond G2 show elevated FSH. So when it comes to looking at the actual levels of testosterone and estradiol in our study, these were really remarkably low, 2.8 for testosterone and only 140 picomoles per liter for the women, untreated, of course. So my understanding of Prader-Willi syndrome is that this is really central hypergonadism caused not by hypothalamo-pituitary deficiency, but by dysregulation. So the actual levels of the hormones may be normal, but they don't work properly because they're not being secreted in a physiological fashion. There's also undoubtedly a primary element of the hypergonadism, particularly evident in pubertal males. And the trouble with studying this is that if you have combined central and primary hypergonadism, it makes the pathology difficult to interpret. Well, here's my first suggestion for future research. Inhibin B and AMH are made in the Sertoli and granulosa cells respectively. I would love to see more data on these hormones in Prader-Willi syndrome with a mixed cross-sectional and longitudinal study correlating levels with age, sex, pubertal stage, gonadotrophins, and the sex steroids. Here are two very good papers, but there more work needs to be done. Well, let's move now on to our clinical findings, and let's deal with the male infants and children. The penis classically is on the small side. It's not usually, micropenis is rare, normal sized penis is rare. Usually the penis is between 2.1 and 3 centimeters. As you would expect, only 2 of our boys had normally descended testes. The rest had cryptorchidism, which is mostly bilateral. Twice weekly HCG injections given to 25 of our boys only resulted in descent in 3 patients. 44 boys underwent orchidopexy. Some of the older boys in the study never had surgery. This was successful in 31, unsuccessful in 7, and partially successful with only 1 viable testis in the scrotum in 8. And as you would expect, the patients with failed orchidopexy, they were born earlier, before 1987. They were older at the time of surgery. An important point I'd like to come back to is that redo surgery was usually unsuccessful in these patients, particularly the 2-stage Fowler-Stevens procedure. Now let's move on to pubertal findings. 37 boys were either aged more than 11 or had been more than 11 years old before they died. And you can see that actually the age at spontaneous G2 and G3, not that different to what you'd expect in the general population. But what is important is that 14 boys did not progress into puberty. They remained at G1, and this included the boys with failed or untreated bilateral cryptorchidism. 15 arrested at G2 to 3 with these testicular volumes, and this included 2 of the boys with normally descended testes, 1 spontaneously and 1 after HCG. 8 boys reached full pubertal development. Interestingly, 3 of them had only 1 viable testis. So let's look at those data. First of all, if you have bilateral cryptorchidism, you don't receive surgery, you probably won't go into puberty. Secondly, even if you have successful orchidopexy, mid-pubertal arrest is common. And thirdly, you don't need 2 testes to complete puberty. Some of our patients only had 1. Let's look now at management. This is a very, very controversial issue. Of the male cohort, 24 were treated with testosterone, just over half. And this was always given as intramuscular testosterone, as Sustanon. And I've highlighted here the doses for you. This was the commonest dose to give, 200 milligrams every 6 weeks. But notice that treatment was stopped in at least 4 patients, probably more, but at the end of the study, it was difficult to get the data due to concerns that the testosterone might be making the behavior worse. Now let's move on to the girls. Hypoplastic labia majora is a classic feature of Prader-Willi syndrome, but this was looked for so infrequently in our study that it wasn't, the information wasn't useful. 28 years either were or had been over 11 years by the end of the study. And you can look at the onset of B2 and B4 to 5, probably a year later or 2 years later than usual. But the principal finding is that of 22 girls in whom data were available, 13 had not completed puberty. They were still B3 or less, only 9 B4 to B5. Also, spontaneous menarche occurred in only 8 patients at a late age, mean 17.1 years. And when it did occur, none of these patients had a normal cycle. Some only had one period, and others had oligoamenorrhea. And nobody has ever, to my knowledge, done pelvic ultrasound or published it on Prader-Willi females. We do so here. And what we found is that the uterine length up to 16 years, using our normative data from Ian Griffin and colleagues, was within normal limits. But the pear-shaped, tubercle-shaped uterus was only achieved in 5 out of 14 patients. So there was underdevelopment of the uterine form. And with the varying volumes, the actual volumes were not different to controls, but there was a reduced follicle count. Okay, what about treatment for the girls? Well, the women were treated far less often than the males. 4 of our patients had norepinephrine to help with breakthrough bleeding, and just 5 patients had an assortment of estradiol replacement. Well, let's move on now to saying how we're going to manage Prader-Willi syndrome. Let's start with the males. And the cornerstone of the male management is meticulous clinical examination. So you look carefully at the position of the testes, normal position, which is rare but does happen, high scrotal, external inguinal ring, inguinal canal, or not palpable. The testes are not palpable, they're either intra-abdominal or they've atrophied. If the testes are not palpable, then you need to perform ultrasound and consider other methods, MRI, laparoscopy. Also, I would recommend considering giving HCG and measuring testosterone, and if you can, AMH, 4 days later to look at testicular reserve. What about the actual treatment? Well, if the testis or testes are palpable at or below the external inguinal ring, then there's no reason why a good general pediatric surgeon shouldn't perform orchidopexy, normally done between the ages of 6 and 12 months. If the cryptorchidism is bilateral, and particularly if the testes are above the external inguinal ring, then I think you should consider referral to a high-volume pediatric urologist with experience in DSD. If the testes are impalpable, then definitely you need an experienced surgeon, and this surgeon will consider giving a long course of HCG injections, perhaps 4 to 6 weeks, imaging before and after, doing biochemistry before and after to assess testicular status, performing laparoscopy to identify viable testicular tissue. If the intra-abdominal testis is identified and it's low-lying, 1-stage orchidopexy. For high intra-abdominal testes, a 2-stage procedure. So let's be quite clear about this. The results of orchidopexy are not going to be as good in Prader-Willi males as in the, if you like, the general cryptorchid population. You know what I mean? There's a good publication on this. And this is because there is an underlying hypogonadism. The more severe this is, the greater the chance of intra-abdominal and atrophic testes with a more difficult surgical result. The second point is that, as I've said already, if there's one viable testis, the patient still has a chance of going through puberty. So repeated efforts to operate on a contralateral testis, if there's one viable testis, is unjustified. You don't want to put these poor boys through more procedures than they need. The other point, another research area for you to consider, is that at the moment there really isn't enough evidence to recommend the routine use of HCG. I would love to see a randomized study where patients were allocated to either receiving preoperative HCG or no HCG. And in this case, you'd have to stratify according to the testicular position. So you didn't have more intra-abdominal cases in one group than the other. You'd have to stratify. That's a really nice study for you to consider. What about assessing males at the age of puberty? Well, obviously the cornerstone is careful clinical examination, genital, pubic hair, axillary hair stage, testicular volumes, height velocity as part of good practice, perhaps measurement annually of LH, FSH, and testosterone from G2 onwards. What about treatment? Well, there are no clear guidelines. And as you probably know, certainly in the UK, I'm sure probably in Egypt, doctors and families are worried about causing temper tantrums and other behavioral problems to worsen. There's actually no evidence for this. And hormone deficiency can give you psychiatric and behavior problems. And there's a very good article by Eiholz's group, which I'd advise you to read. So in boys who remain G1 beyond 13 years or G2 to 3 beyond 14 years, you could consider this very standard regimen using either oral testosterone undecanoate, or intramuscular testosterone ester, for example, sustanon. And this is a pretty standard regime that you'll probably be aware of. Thereafter, 3 monthly injections of testosterone undecanoate, libido are recommended. And you can, of course, modify the dose according to the wishes of the patient and the family. So these are the learning points I'd like to raise concerning the management of puberty. In the absence of any real evidence to say that testosterone treatment causes behavior problems, you're entitled to recommend standard pubertal induction and maintenance, as I showed on the previous slide. The other thing is that a double-blind, randomized, placebo-controlled crossover trial of androgen treatment is needed. And I'll show you this in the next slide. The eligible patients would be boys, of course, with PWS, aged 13 to 15 years, in whom androgen replacement was considered appropriate because they remain G1 after 13 years, or they remain G2 or 3 after 14 years, and you're anticipating mid-pubertal arrest. So this is what I'm suggesting. And I would love to see the study done in Egypt, but I suspect we probably need to make it a Middle Eastern study and involve other countries too, because of the rarity of Prader-Willi syndrome. You need about 12 patients. You would randomize them to receive either the Standol or placebo for 6 months. And after 6 months, you'd cross them over. So they'd have, if they had Standol, they'd get placebo, they had placebo, they'd have Standol. And they wouldn't know, the clinician wouldn't know which they were receiving, whether active androgen or placebo. During this year, including the crossover, the family would keep a record of temper tantrums. And this is a Donaldson grading. I'm sure there are better gradings around, but this is 1 would be mild, 2 would be enough to sort of cause an occasion like a meal to be abandoned, and 3 would be a temper tantrum involving damage to furniture or even to people. And after 12 months' time, you would break the code. And my hypothesis would be that you would not see an increase in the number or severity of temper tantrums on treatment. Of course, this could only be a qualitative study, but Prader-Willi syndrome is so rare that we have to resign ourselves to dealing with small numbers. Let's finish then with just the assessment of hypergonadism in females. Again, good practice, careful pubertal staging of breast, pubic hair, and axillary hair, height velocity, perhaps annual measurement of gonadotrophins and estradiol from B2 onwards, and perhaps pelvic ultrasound as an aid to guide you as to how much estrogenization there is of the uterus. And as for males, there are no evidence-based guidelines, but the fact is all female patients demonstrate hypergonadism, that they're all hypergonadal. So why shouldn't they receive the benefit of a pubertal induction program if they're showing no signs of puberty from, say, 12 years, or just they're stuck at B2 after 13 years? Now, I don't have time to go into detail about the protocols, but the protocols that we worked on in the Turner Syndrome Working Group oral and transdermal, both using natural estradiol. These are the regimes I would recommend. They're applicable to Turner syndrome and to Prader-Willi syndrome. And again, this paper is an easy download. This is the paper we published in Hormone Research in 2019. Well, that remains for me now to thank all the patients and their families who attended our multidisciplinary clinic in Glasgow over the years. My successor in the clinic is Gufta Sheikh, who remains a very good friend and colleague. I'd like to thank him and the Glasgow team for their support. I'd obviously very much like to thank my co-authors. I've already mentioned Heba and Sameh, but also Sakina Kera from Algeria, Mariam Karim from Morocco, Filiz Sismeki from Turkey. And I'd like to dedicate this talk to our lovely orgazologist, Wendy Patterson, who died very tragically, far too young. She was only about 55, 56 in 2012. It was Wendy who collected almost all the data for the study, certainly up to 2011. And very sadly, she did not live to see it published. So this talk is dedicated to her. Thank you very much indeed.
Malcolm, thank you very much indeed for your excellent presentation. I think I helped you in publishing a paper for 28 years experience in Glasgow regarding Prader-Willi. And I think this is the biggest series all over the world about Prader-Willi, isn't it?
There are some, the Dutch experience, they're very impressive. I think they had 68 males in one of their studies. So we're one of the biggest. I think what I would say, Sameh, although this is in some ways quite a messy study, there's missing data and everything, at least it is the duration of follow-up that is important. Yeah. We've got follow-up for, as I said, a median of 11 years. So, and we did learn a lot from following patients through and seeing that boys, despite having normally descended testes, still could have pubertal arrest. So the correlation between testicular status at 2 years and pubertal stage, it isn't 100%. And so that's what we learned. Really, the follow-up in the study has been very helpful. So thank you. And thank you for your contribution in the United Trophies. It's interesting, isn't it, that the levels in Prader-Willi syndrome, they're not different to controls apart from FSH levels in pubertal boys. And so I think we are really dealing with, it's a hypothalamic dysfunction, dysregulation, not a classic deficiency state.
Do you know that now in Egypt, last protocol, we included Prader-Willi as an indication for growth hormone therapy in the Ministry of Health or Health Insurance Organization. And it was a big step forward for including the international either EMA or APD approval indication for growth hormone. And nowadays, we have a lot of patients with Prader-Willi. Previously, we couldn't pick them up, but nowadays we couldn't, and they're doing to some extent not bad. So thank you very much for raising this point. Yes, thank you very much for your help.
Okay, just a quick word about growth hormone. The great thing about Prader-Willi syndrome is the management of the family, and the cornerstone of management really is the weight control, the dietary control, educational placement, ensuring that the family embark on leisure pursuits, including swimming, taking exercise, have a healthy lifestyle. Of course, growth hormone is important and has a role. And of course, pubertal induction management is important. But I've concentrated purely on the hypergonadal side. But of course, in real life, you look at the whole patient, the whole picture. And you can't just get a girl to have, with Prader-Willi syndrome, to have periods, for example, without discussing the question of how the hygiene will be managed by the family. So there's a huge amount of this talk, which I've not been able to say. I do want to emphasize, I've only taken just one narrow area. Thank you.
Great, thank you very much. Mona Karim, may you please introduce Dr. Abdul Moeen?
I'm sorry, could you repeat the question?
No, thank you very much, Malcolm. I was talking to Mona Karim. Thank you very much. Thank you.